recording this webinar right now. The purpose of this is that there are many people who were unable to join us today, and I think if you would like to listen in on this discussion, this gives them the opportunity to do so. So with that, I'd like to just give a brief introduction about what we're going to be talking about today, and then I will introduce our speakers. Currently on the line, I know we have two of the three, and I'm trying to make sure our third one joins us as well. So as all of you know, this request for information was released several weeks ago when the series if I could just have people mute themselves. Thank you. This particular question has been raised now around direct provider contracting over the years in different guises. This is an interesting question coming from the Innovation Center, given that we are in the midst of multiple other innovations underway. And we felt it was very important to have a voice in this conversation. So this is a great opportunity for people who are involved in primary care transformation efforts in a multi-payer space to comment on what may be yet another program that the Innovation Center is considering rolling out. As just a personal bid and request, I would ask that if you are considering sending in comments in the public comment time period that we have, which is only till the end of this week, that if you are able to do so and share that information that you are sending your comments to CMS with us at the fund, that would be incredibly helpful. We're really happy to serve as a hub of information and be able to share that amongst our colleagues. So my request is, first of all, please make comments and send them in if you have something to say. This is an opportunity to have some impact on the decisions that are being made at the Innovation Center. And if you do send in comments or a letter, if you're able to share them with us at the fund, and if you're comfortable making that public to our colleagues who are on the phone and our other colleagues who are unable to be with us today about this, that would also be very useful. With that, I'd like to just turn to, and actually just as a reminder for those of you who've just gotten on the line, please put yourselves on mute if you're not actually speaking. And also this is being recorded so that you will be able to review this again if you wish, or send this on to your colleagues if they want to hear the discussion and were unable to participate today. That will be on the Milbank Memorial Fund Multi-State Collaborative webpage sometime either later today or tomorrow. With that, I would like to turn to one of our two colleagues who has incredibly graciously offered to speak today, and I know who is on the line. Dr. Judy Yerzin is an incredible advocate for primary care, for Medicaid, for healthcare in general, and truly for health equity. Judy serves as the medical director for the Medicaid agency for the state of Colorado, and she has very graciously offered to offer some of her opinions about this topic. Judy, I'm going to turn it over to you and mute myself. And thank you very much for joining.
I have a question for you quickly though, Lisa. Are you going to go over the slides at all?
I was not, but I can. Do you think that would be?
Because that might be a helpful sort of framework, and then I have ideas on top of that.
Absolutely. So let me, it'll take me a second to get that. Sounds like. You're testing my technology capacity here. I want to say this is extremely scary. Okay. Got it. Can people see the screen?
Yes.
Excellent. Yes. Great. So I'm going to just march through this quickly. These slides we shared with our colleagues at a meeting that was now 2 weeks ago in Baltimore. It was we sort of piggybacked on the annual 2018 summit that CMS has for the CPC Plus, and we took the opportunity to meet with our colleagues the day before for the morning and talk about some other areas besides direct provider contracting, but one of them was this. So this actually gives us a little bit of the context. The Innovation Center is seeking comments on testing potential direct provider contracting models. And they did release a request for information with input that is now due at the end of this week, so Friday of this week. I believe it's probably a minute before midnight. The goals that we've observed, and just was a little bit of analysis just of the way this was written, but the stated goal is to reduce healthcare expenditures while preserving or enhancing the quality of care by testing a model where beneficiaries voluntarily enroll in a practice participating in said DPC model. And there were some specific attributes that were described, although a great deal of information is being requested by our colleagues at CMS, hoping to find a model that they would like to test. But specifically, they were looking for enhanced access to physicians and potentially other providers' services for the beneficiaries of Medicare. They wish to reduce the administrative burden on providers and suppliers for billing services. And they wish to create and establish really a revenue stream, which is presumably a portion of which would be per capita, that would aim to give providers and suppliers more flexibility in how and where they care for their patients. So we did a little bit of background conversation and I identified a couple of issues that may come up. One is certainly how do you define a set of services? How would you set payment rates in this setting? How would you create risk adjustment? How would you define access to the practices? And really that really comes under the category of protection for consumers. And how would you determine a mechanism for patient incentives to, for them to stay with the practice that they've identified as their primary practice and avoiding what's referred to in the industry as leakage? So we were looking at a couple of other questions, and this, some of this really did appear to resonate with the people we were talking to in Baltimore. One is that there's just some concern about innovation overload, that, you know, for the innovative practices that really want to be part of the new paradigm of delivering care, for the payers that are willing to support this, there can be some real concern about innovation overload. People just being, you know, overwhelmed by the amount of options and frankly the amount of work related to putting these payers that are involved in CPC Plus is what happens to the CPC2 track 2 payments. Really trying to figure out if we can learn some lessons from the accountable care organizations and the CPC Classic programs, and that appears to be moving towards targeting a high-risk population, but you're talking about a larger population than that, obviously, with direct primary contracting. There's some concern about our colleagues at the Innovation Center having the resources they really need to put yet another program into place. And that's, you know, we work very closely with our colleagues at the Innovation Center, and it seems that their staffing is sometimes a struggle to maintain the work that they're doing. And then, of course, what would be the impact of this program on the total costs of care? So the question for our payer colleagues is, why weigh in on this? Well, we have a couple of ideas. One is that we believe that the direct provider contracting test may well be a multi-payer program like the CPC Plus. It may be indeed actually required for those insurers that are involved in Medicare Advantage programs. We are concerned, as we said, about the impact on existing Innovation Center programs such as ACOs and CPC Plus in particular. And then certainly, if CMS takes this route, there is always, appropriately, the rest of the industry will be watching closely. And perhaps it may be something that has to be rolled out quickly. So this was just a list of the things that we at Milbank were going to do in order to try to get as much information into your hands as possible. Certainly, we've been publicizing the tight timeline and the existence of the request for information. This webinar we were able to schedule for today, thanks to all of you. I'm in the process of working on a letter that we will be sending from the Milbank Memorial Fund, but on behalf of the fund, not on behalf of anyone else. But I will be circulating that language probably in the next day or so that people can see what we are going to be sending. And hopefully that would be helpful to perhaps give you some ideas or clarify your thoughts or make other decisions about how you'd like to comment And then, as I said, wish to send or will be sending to CMS, I would like to be able to circulate that among our colleagues in the multi-state collaborative, because I think that's useful. And the deadline for comments is, as I said, this Friday, the 25th of May, and that gives us very little time. So really happy to be able to have done this webinar today. So Judy, if I could turn it over to you, that would be great. Thank you.
Certainly. So I think I want to start off by saying, I think we all agree primary care is essential and critical to be done well to improve the health of populations and of our members. And I will say that I'm intrigued by the idea of direct primary care and also reasonably cautious. And I think some of the things in particular for Medicaid are that, and I'm hearing a bit of an echo. I don't know if everyone is on mute or not. It's hard to talk and hear yourself.
Absolutely. So I just muted myself. I'm going to mute myself right now, Judy. That was me.
Okay. We'll see if that helps. So I think, as you laid out in your slide, the defined suite of services, I think some of the things that are really important for the Medicaid population are some things that happen in a team. And some direct primary care models are, at least that I've seen in Colorado, are a single or a trio of primary care providers. And I think figuring out where the behavioral health fits in, addiction, screening and services, and how folks get connected to more than just your physical health is really critically important to think about how that might fit. I think some of the risk adjustment issues give me pause. In particular, how do we make sure there's not cherry picking of these folks? And do we pick the sickest? Do we pick the least? Do we let people decide? All of that has potential implications for how well this might work or not work. I think in terms of access and what people get, there's some pieces to think about. In particular, I think figuring out what, besides can you get access to the things that you need, the specialists you need, are there potential harms that you don't get screenings you need, that you don't get some of this? I think figuring out where, particularly for the Medicaid population, the social determinants of health fit in, and how do you have those connections to community resources. That might be done quite well in these models, or it might be missed and then you get more ER visits, you get more trouble. So I think that is a potential challenge to these models. And I think an example, some of you heard me speak before, one of my favorite soapboxes is that Colorado Medicaid has been paying for depression screens $10 a pop on top of a primary care visit, and we have very few people that bill us for it. And so the potential advantage of this model is that we could just expect that that happens and it fits in there. But the disadvantage is how would we measure whether that happens or not and make sure that people are getting the care that we think they need. And then I think enough said about innovation overload, and we are also, besides the comprehensive primary care initiative, we also have a state innovation model grant. And in recently recruiting for our third cohort, there were fewer practices than we thought interested in it. And I think that that sort of that reflects that there's a lot going on in this space and in primary care transformation, and those that are interested have jumped on board, and those that are not ready perhaps have not. And then I think the final thing for Medicaid folks is that we are very interested in doing CPC Plus Track 2 and has been totally stalled out because it requires an 1115 waiver. And I think that this would probably also require an 1115 waiver, which is potentially pretty burdensome. And so I think that, are there other ways to get at this or to support primary care in different ways through a more defined payment that's a bit predictable? I think I would be interested in exploring these options, and I'm not completely sure that this is the right one, but I am completely sure we want to support primary care to the extent that we can, because I think that's really the linchpin of improving the health of our population. Thanks.
Julie, thank you very much. I really appreciate your comments and your thoughtfulness. I think what I'd like to do is turn this right over to Dr. Stephen Peskin, who's a medical director at Horizon Blue Cross Blue Shield of New Jersey. They have some very specific experience with direct provider contracting in their local practices, and Steve is on the phone, so you will not be able to see him, but he will be able to speak. Steve, are you able to speak right now?
Sure. Thanks, Lisa. So we've had some experience for about 3 years. The state of New Jersey put out a RFP around direct care, direct provider contracting. Actually, it was direct primary care. So DPC can be initials for direct contracting or direct primary care. Work that I did in terms of looking at our clinical partners, there was a real difficulty in meeting the requirement that the practitioner, the clinician, she be direct care only, and capping the panel to 1,000. And existing practices were very concerned that it would take well over a year to build up that kind of panel, or perhaps possibly 2 or 3 years. So basically, we didn't have any of our existing patient-centered medical home, CPC classic organizations to be interested, and 2 groups, Our Health and Paladina, were awarded the bid from the state. To date, the experience is not a lot of persons. The state health benefit plan is the only, which is of course very large, over 600, 700,000 people, with Horizon and Net being the insurers for that self-insured, large self-insured group. And there is no selection bias, because the state health benefit plan person self-select, and then looking at classical triple or quadruple aim measures, looking at total cost of care, total medical expense, risk adjusted, HEDIS quality measures, patient experience, patient satisfaction, and then what the clinicians say about their experience working in direct care. I have one anecdote, a colleague now, Dr. Prater, who actually stood up the Our Health primary care practice in Ewing, New Jersey, and now works for Horizon, said that from her N of 1 perspective, it worked very well in terms of the amount of time that she was able to spend with each individual, a true team-based approach looking across chronic conditions, behavioral health, social determinants and the like. And so again, that's anecdotal, N of 1, but have a lot of respect for Randy as a clinician and as a person. So I would say that's high praise as far as her direct experience. Beyond that, we have had some groups approach us about direct care, but given certain requirements in New Jersey that patients can't be charged additional for the services that are covered, it really doesn't allow direct care within the traditional insurance model. So we're kind of at a bit of a standstill there. We've been certainly deeply involved, as folks I think know, with, again, CPC Classic and now CPC Plus, and a lot of energy juxtaposing our patient-centered medical home ACO work with CMMI and CPC Classic and now CPC Plus. So in brief, it's been a pilot in New Jersey with the largest private, public/private payer in the state. embarking on this journey about 3 years ago with two organizations, actually neither of which had previously been providing care in New Jersey, that being Paladina out of Colorado and Our Health out of Milbank. And don't have a lot of results, Lisa, to report other than, again, the anecdotal information from one stellar internist, and that's about it.
Thanks so much, Stephen. Just a reminder that I'm still hearing a little bit of background noise and can hear typing if people can make sure that they're muted when they're not speaking. Stephen, can I quickly ask you a question in terms of what, if any, sense you've gotten about patients' perceptions of dealing with this new paradigm?
Yeah, I have not seen any of the patient-reported outcomes or patient experience of care from the state health benefit plan in terms of their tracking the experience of the persons who self-select. Again, it's totally, Lisa, by choice. They're not sort of trying to guide people with multiple chronic conditions toward direct care, nor are they trying to guide cherry picking of the healthier person. So it's an important question, but I don't have an answer for you. But I'll see if I can get some information from the state in terms of what the employees who've chosen direct care are saying about it.
Great, thank you, Stephen. So there's a lot of loud noise in the background. I don't know who that is. I may have to mute everybody.
It's somebody who's obviously not paying attention, and I just wish they'd hang up or do something else.
Okay, well, thank you. It sounds like they might have muted. That's great. So this is Lisa Watkins again, and thank you both to Judy and to Stephen. I'd like you both to try to stay on the line, and I'd like to turn over to our third presenter, Julie Shills. Many of you have known over the years in her tireless work on behalf of primary care transformation. She has been with Anthem for quite a while and has most recently moved to a new position with Mathematica Policy Research. Julie, we're delighted to have you speak with us today. I'm going to turn it over to you.
Great. Well, thank you so much, Lisa. And just a little bit of a disclaimer for everyone. I'm honored to be asked to join once again, even though I have moved from Anthem to Mathematica. But I just want to let you know that my comments are more from the opinion perspective, and I have no insider knowledge from CMS or CMMI that would be directing any of my comments. They are really the comments of Julie Shills from the work that I've done, not only being capitated within a provider organization, but also the work at Anthem. And so one of the things I think was actually a little bit telling is the change of nomenclature to direct provider contracting. And while, I think in talking to other folks in some of the professional primary care organizations, it's the understanding that that does have some significance from the term we know, direct primary care, and the model that we all kind of tend to think about. So I think within the structure of the RFI, which I will admit in some places was a little confusing to try and understand the signals that maybe were being sent to us, but I think it's, in the spirit of attempting to get out a new model related to advanced alternative payment models. This, CMMI wanted to get something out so they could start the dialogue. But when you look at the language and thinking about direct provider contracting, it does suggest that there's an opportunity to open up the providers in this space to include specialties. And then you think about the word supplier that was used in the context of the RFI as well, that in my mind opens up, questions of, is this a model such like Iora Health has, or is this, including retail clinics somehow in an APM model in much broader care delivery? Again, those are more questions than answers, but I do think it's significant that the change in language to direct provider contracting. I would echo some of the statements around not cannibalizing some of the current models. I think we've discussed that before on these calls, and that seems to be surfacing from a lot of individuals, that we are working on some things. We know components that are starting to be successful. We also know that there's still work within some of the ACO models and Medicare, that providers aren't wholly always being successful in those models. And so we want to make sure that as we're testing these out, we're not, we're testing them in a way that we fail forward in some cases and share those best practices. If you think about the flavor, and I'm hearing a little bit of typing again, so we just ask, it's very intentional and quite powerful, ask that you go on mute. History would, the sense in the RFI is lending itself towards furthering into a capitation model, and history would tell us about capitation that size does matter with that. So while the RFI also talks about broadening models for rural and small practices, I think we have to be cautious, knowing history about capitation, that size does matter in terms of your risk pool and having enough patients in that model that you're not lending yourself to additional risks. So circling back on attribution models, and these were raised in a lot of the questions in the RFI, risk adjustment, the risk pool, what's in the capitation number, and can we have some flexibility from that perspective to allow a broader set of providers to be able to participate. Just going to ask again if everyone could go on mute. Great. If I look back to the lessons learned, I was in a provider organization in the 90s, and we had capitation on both commercial and Medicare Advantage plans. I think, and when we first started the capitation model, there were some assumptions made both on the health plan side and our side as a provider group. One of them, from our perspective, we thought, great, we now have control. We can do what we want. We can organize a structure. We'll get this payment, and we will, proceed in a model of care that we think will bring the best value, which is a worthy goal. I think our health plan partners thought, wow, we'll push this to the providers, and I say that in only the kindest way, and we'll have less administrative burden. But in a lot of ways, what we learned is this is a model that you need even more collaboration with, and data to be able to support, and a lot of frequent touch points in capitation to understand what's going on in the market. It is something that the local influencers, whether you have a bad flu season or some sort of community tragedy, can really tend to impact capitation as well. So it's worth kind of, going back and thinking about some of those lessons learned we had in the 90s into the 2000s around capitation, and stepping into current state and thinking about, how do we need to think about this just a little bit differently in the model. One of the other elements as a provider group that we needed to work with our constituencies in our provider group was that we found some under capitation were referring more to specialists, and that wasn't the intent, so kind of monitoring what the patterns might become, and it goes a little bit in line with what Judy was talking about in terms of cherry picking and lemon dropping, and how it might change the patterns within capitation to manage effectively, but assuring that it's a strong base of primary care in the models. So Lisa, with that, I think those are some of the comments I wanted to make from previous experience, and I will turn it back over to you.
Thank you so much, Julie. First of all, I want to thank all three of our speakers for both their commitment to this work and for their willingness to speak with us today and to answer some of the questions that I'm sure many of you have. So I'm going to open this up for discussion. Once again, I just want to remind people that we have 80 people on the line, and it's just a little hard to manage everybody in terms of making sure I can mute individual people. So please, if you can mute yourself if you know there's some noise going on in your environment, that's really helpful. I'm going to ask a question that came in on the chat function right away. This is from our colleague Bill Golden in Arkansas. And he has a specific question about the perception of the American Academy of Family Physicians approach to direct contracting versus the patient-centered medical home concept, of which they are clearly a very strong advocate. But he has, I think, correctly observed that there's a strong support for direct contracting approach at the AAFP. I don't know if anybody wishes to share some insight they might have or observations about that particular question. And Dr. Golden, if you wanted to elaborate on that question before we get the discussion started, I'm happy to have you do that.
No, nothing to elaborate, just I know they're a big advocate. That's a strong push for them to have direct contracting, which may not be what CMMI or CMS has in mind also. There are a lot of people in organized medicine who thought that this initiative was going to be something different than what it is.
Does anyone wish to try to answer the question?
Yeah, Lisa, hello, Bill. This is Stephen Peskin. So similar to the American Academy of Family Physicians, which has been more vocal, as Dr. Golden, a leader of the ACP, and myself as well know, the point of view of ACP is a bit more muted, but the notion that from what I've seen, Bill, from the sort of classical private practices, that CPC gets the insurance companies out of the way, gives me an intimate connection back to my patient without lots of paperwork. And so when we had some weighing in, Bill, by certain people on the Medical Practice and Quality Committee, which I'm privileged to serve for ACP, and we'll be talking about direct care on Thursday in Washington, that the CMMI government-funded healthcare approach does not comport with how perhaps certain parts of organized medicine are looking at DPC, Lisa, where basically you're getting the payer out of the way versus having the payer insinuating itself in the contract.
So I guess this is Lisa. I have some confusion just about what it means to, quote, get that payer truly out of the way. I mean, the payer on some level is the... Well,
the patient has a contract, Lisa, with the doctor, not dissimilar to concierge care. So the patient is paying $70 a month or whatever, is getting comprehensive, person-centered, presumably high-value care. So how do we measure that? And then the wraparound is high deductible health plan or services for the subspecialists that are paid on whatever basis they're paid on, usually fee for service based on a fee schedule.
Thank you, Stephen. So this sort of cuts to the chase on some level. In terms of the language that Julie alluded to, and using the exact same acronym for what appear to be two related but nonetheless distinct concepts. So the direct primary care concept and the direct provider contracting, which isn't necessarily just that. So Julie, can I turn to you just to maybe expand on that a little bit?
Well, you know, I think that this is right, and Bill alluded to it, that, you know, people may be thinking, because the acronym is DPC, that what has been talked about in the provider community being direct primary care is what the RFI was alluding to, but that's where I'm not so sure it does. It uses the same acronym. It talks about some of the components of building the relationship between actually provider and patient, which is certainly a component. It does discuss, you know, decreasing administrative burden, which, you know, patients over paperwork is something that we've heard from this administration, but I think there's, you know, it's an opportunity to delve more deeply into what, you know, what that might look like. But the questions in the RFI don't necessarily sort of get deeper into that as much as, from my perspective, kind of talk about elements that you would think would be related to capitation or taking on more risk. So that's, you were right, Lisa. That's why I think the language change is actually significant, direct provider contracting. And while I haven't talked to my friends at AAFP, and I don't know if there's anyone else on the call that has a relationship with them, and talked with ACP a little bit, and I thought Stephen did a nice job of kind of highlighting the ACP's perspective. It does seem different than the direct primary care model that is discussed from an AAFP perspective. You know, and I will say, I do think this brings up, you know, one of the things I think all of us have seen in some of the models is, while we want our payments to go to primary care and go to actual care delivery, and what we find in some of the constructs, and some of that has to do with, you know, new testing of models, but one of the things I think we do find is that there's some administrative burden, and it tends to be that the payment goes to setting up the structure to be able to be in a value-based payment versus setting up the structure to be able to be organized in a way to deliver evidence-based care. And I do, you know, that is, I think, probably from all of our perspectives, an opportunity in our healthcare delivery system to start to focus, you know, can we get to those metrics that matter, or the data that's shared, in a way to understand that value is being delivered from a patient care perspective, and we are hitting on cost, all of the elements of the quadruple aim, but do it in a way that's certainly more efficient and less cumbersome for any type of practice to be able to participate in, from the small independent practice that doesn't have a lot of necessarily capabilities or extra bandwidth, to the larger organizations, because we still would rather that their work is focused on delivering care.
Yeah, I just want to follow up on some of that, just because the terminology will be confusing. I appreciate your comments from Julie, and I think you're spot on, and I'm just trying to get a handle. The term direct contracting means a lot of different things to different people. And there'll be some folks, even on the more right of center, that think direct contracting means you list your prices and you can balance bill. And I think that there's a whole variety of it. The term is becoming a Rorschach blot, and I think it'll cause all sorts of confusions in public discourse because of that term.
So thank you for both of you. That was Dr. Golden and Julie Schills. I think that maybe this would be an important piece to emphasize in comments to our colleagues at CMS that are submitted in this week.
One other caveat is, as we talked about at CPC Plus, at the lovely Newark Airport that primary care is a team sport. And one of my colleagues was saying when she looked at this that it seems to be going away from that, and smaller panel sizes where we have too few primary care doctors, whether she be an internist or he be a family physician or, for that matter, advanced practice nurse. And so we have too few. So if we're compounding that problem by reducing the number of a person's panel size, say from 2,500 to 1,000 or something like that. And so you're exacerbating a problem and you're going away from team-based care toward continuing the 1950s version of the fighter pilot physician.
That's a really good point, Stephen.
Although fighter pilots now rely on computers, so.
But the point of having the concept of the team and how the patient-centered medical home so very much rests upon that is a really important piece. So thanks for bringing that up.
And this is Judy. I think the multidisciplinary team part of that is really important. So not only care coordinators and nurses, but also potentially pharmacists and then social workers or some sort of behavioral health counselor. I think in a well-functioning primary care practice, many of those pieces are there or are linked very tightly, and figuring out how to make this contracting work in a way that team is there is I think important for success.
Sorry. Baked into the structure of any sort of model would be essential. Are there other questions or comments? A lot of you have been very sort of hanging on listening to this, and I'm really delighted to have you all join us today. Any other questions or comments for either from some of our conveners who are on the line or other payers?
Yeah, this is Dr. Weisel out of Montana. I think one of the things that we have to look at and make sure that CMMI looks at is inclusiveness. Obviously, I live in a frontier, more rural state, and the concept of having resources to operationalize any model might be a challenge. So just, my comment is try to do everything we can to look at regionalization to be more than urban settings.
Thank you. Dr. Weisel, do you feel that that's a clear threat in terms of the smaller rural practices?
Right now, I'm not sure anything's clear. But I think it's a challenge. It's a challenge that we know that what CMS finally does will eventually become the payment model for most of our country. So finding a way to include all of our country, including those in urban, suburban, and rural areas, is necessary. Otherwise, it'll be a dead-end road.
Thank you. Any other comments or questions? We have a couple of folks on the line who are in Oregon, where you have I think there are 17 payers, perhaps, including very small rural, I should say small, but sparsely populated rural areas, as well as some major urban centers such as Portland. Have you heard, and there's a tremendous amount of innovation going on, obviously, at the state level in Oregon. Have any of you witnessed anything that you think would be contributing to this discussion in terms of this potential mechanism for payment?
Hey, Lisa, this is Susan Stewart. Can you hear me?
Yeah, Susan, thanks for joining in.
Sorry, I'm not from Oregon, obviously. I wanted to just focus on a small issue that I can't let go of in this RFI, and it's come up a little bit in CPC Plus. I heard it in the listening session on May 8th, which is, practices are feeling really challenged in the CPC Plus model with the lag in HCC scores and risk adjustment and, one, just the timeline, but two, how does updated information about issues, diagnoses with a patient get reflected if you're not dropping a claim because you're undertaking non-visit based care? So that's a CPC Plus issue, right, that they're trying to navigate. But I feel like this is rife through this RFI, which is, there's this theoretical construct of trying to limit administrative burden, which I think we all think sounds great. But I wonder for the practice, how you do the quality measurement and how you make sure that your per member per month rate is reflecting where the patient is. If there isn't this stream of claims, there's got to be some kind of administrative mechanism. And I think I had wished in the RFI that CMS was putting forth a couple of concepts and asking for feedback. Right now, it just feels wide open. And, it seems to me that primary care providers could get stuck in a difficult place unless that's thought through carefully.
Susan, that sounds like a really important question. And I guess one of the ways to maybe get some further information is to really push that in comments and saying this is of very high concern level. So I think you're right. Judy, or
I was just going to add, I agree with everything you said, Susan. This is Julie, and I think this is where we do need to test some ideas versus kind of going out big and bold, because the implications are incredibly significant. We'll either be paying too much and not getting the value, or we won't be paying enough for the value that we're receiving. And those are both of those have implications and need to be thoughtful about how we accomplish that.
Julie, do you think this is a function of this RFI being rolled out relatively quickly, and maybe that before they really had shaped something that might start to answer Susan's concerns that she raised, that it just sort of not exactly the cart before the horse, but a little bit of a relatively quick turnaround and an RFI that really poses questions in such a way that is just left wide open.
And this would fall into Julie's personal opinion, and I think it's true. I think they probably wanted, and I appreciate this. I think it does reflect that, probably the good news is there isn't necessarily a model that is actually already developed and it's going to be rolled out. This is truly an RFI to get our opinions and actually, incorporate them into a next discussion. And when an RFP or a new program will come out, I think remains to be seen. But it's sort of, this is the early work of CMMI to get opinions. And the other comment I will make, I do think, I personally think that the structure of CMMI has been positive. It's been good to participate in the innovations that have come out. I think there have been lessons learned for all of us as we participate in the structure. And another opportunity for all of us in any responses is to just indicate that, because prior to this RFI coming out was the quite numerous responses to what direction should CMMI take. which I don't know that there's any way to sort of organize what was received into anything, but, you know, we can add to our comments as appropriate. That CMMI, I think, has been a good structure and should continue.
Absolutely, and this is really an opportunity to express our explicit support for CMS's ongoing programs, of which almost everyone on the phone is participating on some level.
This is Alicia.
Yes. Hi, Alicia. Welcome.
A bit of a follow-up to Julie's question. So this is an RFI, and I feel like in some ways when I read through it, I have more questions than answers to respond to it, because not understanding the terminology and where they're headed maybe. And then I also have Susan's concern as well about the codes and the lack of codes, because we want to get to the ECQMs and go to the clinical data, but until we get there, which I think we're a ways away, we have to rely on the claims data, which it makes me nervous of not getting that. So as we're gathering our information, we're going to respond to this RFI. Is there a typical response time, like when we respond to these RFIs with CMS? Because I know it wasn't that long ago about the new direction of CMMI that we responded, but I have not seen any kind of feedback or organization about what they received and what was going to be worked on, and before this came out. So do we have any direction or any thoughts on timing if we respond to this, what our next step or how it would go?
This is Lisa. I don't think we actually do have a clear idea about that. In terms of the the new directions, none of those responses were made public until the day this RFI was released several weeks ago. And I think that it's not clear what kind of capacity the already sort of overstretched staff has to sift through comments, et cetera, and then make a decision about what the next steps are. That being said, I am perfectly happy to pose that question to our colleagues at CMS, whom I meet with regularly, and I'd be glad to report back on that, to at least get some sense of a range, and if they're able to share that with us.
Thank you.
But I think it's an issue. You certainly don't want your hard work and comments to go into a vacuum, which is a little how it felt with the previous RFI that many of you responded to. So I think that is a reasonable question, and I think we can pose that. So it's about 5 minutes before the hour. Are there any other questions or comments from those of you who've been on the line?
Thanks, Lisa, for setting this up.
Absolutely, and first of all, thanks to all of you, and special thanks to our speakers, Julie Schills, Judy Zerzan, and Stephen Peskin for sharing their experience and wisdom with us. We really very much appreciate that. I want to once again just make a really strong pitch for you and your organizations to submit written comments to CMS in response to this request for information. I really do believe this is our chance to participate in the very beginnings of this conversation. And I think they are truly looking for advice from those that have been through the various iterations of this type of innovation. So once again, please send in your comments. I will be sharing ours with everyone on the line here, as well as anyone else on our mailing list when our letter goes out later this week. And I'd really like to once again ask you to, if you're willing to share what comments or letters you will be sending to CMS, that would also be very helpful to everybody as we puzzle through this together. Thanks so much, everyone, for being on the line. As I said, this has been recorded. Please let your colleagues know if they wish to listen to this conversation, they can do so. Thanks, everybody. Bye-bye.